Okay, Bismillahirrahmanirrahim. This is our part 2 of the upper limb Viva questions that can be asked to you in your Viva question. Now, starting from question number 1, that is our question number 89. Why is a scaphoid prone to avascular necrosis? Because his blood supply enters distally, proximal fragment loses blood supply after the fracture. Which part of the scaphoid undergoes avascular necrosis? Most often proximal fragment, as we have already discussed. If you know the question and the answer, you can easily give the answer. Do not get confused in the Viva and just be confident. You know, if you know the answer, just give the answer straight away. Viva is a one-to-one station. The facilitator asks you the question and you give the answer. If you do not know the answer, skip the question and ask the facilitator to please ask me at the end of the Viva. Okay, do not waste your time because the Viva time is limited. Otherwise, you are going to lose your marks. Okay, this was the key to attempt your Viva. I am going to make another video for that as well. Question number 91 is the name another upper limb bone that may undergo avascular necrosis, and that is head of the humerus, which is after the fracture of the surgical neck due to injury to anterior and posterior circumflex humeral artery. Clinical importance of AVN in scaphoid fracture is avascular necrosis is non-union chronic waist pain and osteoarthritis. Which nerve passes between the two heads of pronator teres? It is a very important question of each facilitator, that to know the knowledge of the to know how much the student know the knowledge, have a knowledge about the muscles, that whether he has learned the muscles, whether in a deep manner or superficially he has just learned the name of the muscles. In the between the two heads of the pronator teres, median nerve passes, and if there is a compression of the median nerve, what is going to happen? There will be pronator syndrome. And what happen in this condition? There will be pain in the forearm, weakness of the flexion and pronation, and tingling in the lateral 3.5 fingers. Radial artery also runs nearby, but it does not pass between the heads, so the symptoms which are related with the radial artery will be remain intact. Okay, which muscle is not usually present in everyone's body? It is the palmaris longus muscle, and it is absent either unilaterally or it may be absent bilaterally in about 10 to 20% of the people. It lies superficial to flexor retinaculum. It is very important. Which there are few questions which are asked, that which structures lie superficial to flexor retinaculum and below the flexor retinaculum, and it is inserted into the palmar aponeurosis. On the palmar aponeurosis, the Viva question also asked from the palmar aponeurosis. The function of palmaris longus is it is a weak wrist flexor, so that's why it is often considered as vestigial. It is used for the grafting in the tendon repair surgeries because its absence, if it is absent in the any person, it does not cause any disability. What is the anatomical snuff box? Here anatomical is written 2 times mistakenly. The boundaries are lateral boundary, medial and floor, and superficial boundary. Anterior lateral or anterior boundaries formed by the abductor pollicis longus and extensor pollicis brevis. Medially, tendon of the extensor pollicis longus. Floor is formed by the scaphoid and trapezius bone, also crossed by the radial artery. This is an extra point. Roof is formed by the skin and superficial fascia. If this question is asked to you in the SAQ, you are going to write it down like this. But if it is asked to you in the OSP, you are going to write it down in a different manner. You are not going to write down also crossed by radial artery. And please do not use short forms in the OSP or SAQs. You must know the full form, and you must write down the full form. Even the full form of AND, that is AND, and should be written. Artery full form should be written. Vein should not be written as V. Nerve should not be written as N. Nerve full spelling should be written. The contents are radial artery, superficial branch of the radial nerve, cephalic vein. There was a mnemonic for it. I have already told you. VAN is a mnemonic. Which branch of the axillary artery is the largest subscapular artery? This is another important question. And there is a clinical importance of the. I have done a mistake over here. Radial arteries palpated in the radial arteries can be palpated in the anatomical snuff box. And at the anatomical snuff box, there is a scaphoid fracture risk and risk of the avascular necrosis. Now come to the axillary artery. Axillary artery, which branch of the axillary artery is the largest? Subscapular artery is the largest branch of the axillary artery. There are 3 branches of the axillary artery, and these 3 parts are divided by the pectoralis minor. It's a very important question from the BCQ point of view. and Viva point of view as well. First part is the superior thoracic artery, third part thoracoacromial artery, which are going to give rise 4 branches: pectoral, deltoid, clavicular, acromial. And then second part has lateral thoracic artery, third part is the subscapular artery, which is the largest, which I have already told you. Further gives rise circumflex, scapular and third thoracodorsal arteries, and there is anterior circumflex and posterior circumflex humeral artery. There is a mnemonic 1, 2, 3 rule. 1. Screw the lawyer, save a patient. Screw S for superior thoracic, 2 for T for thoracoacromial, L for lateral thoracic, and S for subscapular, and A and P is for anterior circumflex humeral and posterior circumflex humeral. 1, 2, 3 rule is what? 1, in the first part only 1 artery is present, in the 2 part 2 arteries are present, and in the third part 3 arteries are present. Okay, now let's talk about the ape hand. Okay, sorry, there was a namaz break. Now let's come to the point again. Ape hand, it is usually asked in in your exam. The ape hand picture can be given to you and asked, and the questions related to the ape hand can be asked to you, or it can be asked to you in the Viva as well. What is ape hand deformity? It is due to the median nerve injury, where the thumb cannot be opposed and lies in the same plane as the fingers. Causes is injury, it is due to the median nerve injury at the wrist, that is carpal tunnel syndrome, wrist cut or trauma. What are the features? Loss of the thenar eminence muscle, thenar wasting, and you must know which muscles are present in the thenar muscles and which are present in the hypothenar muscles. Thumb is abducted and laterally rotated, resembles an ape hand. There is loss of opposition of the thumb. There is weak flexion of the lateral fingers. There is sensory loss over the lateral 3.5 finger. In clinical importance is important to differentiate from claw hand and wrist drop. When there is a claw hand deformity, ulnar nerve is going to be damaged, and you must know that ulnar nerve is present at the back of the medial epicondyle funny bone, and wrist drop is due to the damage to the radial nerve, okay, which is present on the radial groove. And ape hand deformity, median nerve injury is takes place at the wrist, loss of opposition of the thumb, and there is thenar wasting. There was the summary for that. A hand of benediction. Hand of Benedict is a deformity seen when a patient with median nerve injury at the elbow or above tries to make a fist. Index and middle fingers remain extended while ring and little fingers flex. There is a median nerve injury at the elbow, inability to flex index and middle finger due to paralysis of the lateral half of the flexor digitorum profundus and flexor digitorum superficialis, inability to flex thumb, loss of flexor pollicis longus and thenar muscles while attempting to make a fist. Only ring and little fingers flex. Hands look like a benediction sign. Sensory loss over the lateral 3.5 fingers. Clinical pearl or exam trap is ape hand deformity, resting hand deformity, that a person cannot oppose a thumb, hand or benediction, only seen when making a fist. Dupuytren contracture is a very important question. It is a progressive fibrosis of the palmar aponeurosis, causes fixed flexion deformity of the fingers, most commonly ring and the little finger. The risk of factors or the cause is idiopathic, most commonly in the men more than 40 years of age, associated with diabetes, epilepsy. Long term, the patients who are taking phenytoin, anti-epileptic drug, alcoholism or trauma. Pathologies: palmar fascia undergoes fibrosis and shortening. Fibrous cords pull fingers into flexion at metacarpophalangeal and PIP joints. Interphalangeal joints, ठीक है, metacarpophalangeal joint, interphalangeal joints. This is the clinical features are thickened band felt in the palm. Fingers, especially ring and little finger, cannot be fully extended. Painless, slow, progressive. Claw hand deformity is due to the ulnar nerve palsy. And metacarpophalangeal joints are hyperextended, and interphalangeal joints are flexed, especially in the ring and the little fingers. It is usually a picture is given to you with a claw hand, and the question is asked to you in the OSPE that what is happening in this picture, and which movement is the patient is unable to perform, or this can be asked to you vice versa, which movements patient cannot perform. One question can be asked to you in this way, and in which situation the patient is present. It means in the claw hand, what is the actual position? The metacarpophalangeal joints are hyperextended and interphalangeal joints are flexed, especially ring and the little fingers, like this. I am going to make a separate video for that, do not get confused, okay? But to try to perform it at your hand. Mechanism is paralysis of the lumbrical, third and fourth and introitial, loss of metacarpophalangeal flexion and interphalangeal extension, unopposed action of the extensor digitorum, hyperextension of the metacarpophalangeal joint and long flexors. Clinical features are ring and little fingers show marked clawing wasting of hypothenar eminence, loss of abduction, adduction of fingers, sensory loss on the medial 1.5 fingers. Ulnar law is seen, ulnar claw, or you can see ulnar nerve injury is due to the ulnar claw hand is due to the ulnar nerve injury, hand of Benedict median nerve injury, may when trying to make a fist, and claw hand is due to injury, hyperextension and metacarpophalangeal joint, and radial artery branches are what are the branches of the radial artery? Muscular branches are two muscular branches are flexor and that supply the flexor and extensor muscles of the forearm. Radial recurrent artery ascend to anastomose with radial collateral artery at the elbow. Superficial palmar arch that supply joins the superficial palmar arch in the hand. Dorsal carpal branch contributes to dorsal carpal arch. Princeps pollicis is artery supplies the lateral side of the thumb. Radialis indicis artery supply lateral side of the index finger. Supplies the terminal continuation is deep palmar arch in the hand. Deep palmar arch or superficial palmar arch is very important, and usually its continuation or ending point of this artery or starting point of this arch is usually asked in the Viva question. Which muscle stabilizes the shoulder joint? Rotator cuff muscles that we have already discussed. Stitch muscle, supraspinatus, infraspinatus, TDs minor, and suprascapularis. Details are these muscles basically hold the humerus in the glenoid cavity or glenoid fossa. Supraspinatus initiate the abduction. You can see please see my fat video, that is very important, in which you can see that how much degree abduction is performed by which muscle. Infraspinatus and teres minor performs the lateral rotation, subscapularis medial rotation. Additional stabilizes muscles are deltoid, long head of bicep brachii tendon, and ligaments of the shoulder. Which nerve is damaged at the medial epicondyle of the humerus? You must know, it is very basic and important question. Ulnar nerve, which muscle is affected or related at the mid shaft of the humerus? Profunda deltoid muscle is attached, and brachialis originates from the deltoid muscle attached is the deltoid. Insertion at deltoid tuberosity occurs, and brachialis originates from the lower half of the anterior humerus. Radial nerve learns in the spiral groove of the humerus at the deltoid.